Here's my request. I made a 5-question survey. It's really, really short, okay? And I'm going to put it up on my page. They should on melanieb.com. They should also offer it to you in lab, but I don't know if they're going to. We really want to improve the physiology lab, but what I need some specific feedback from you guys about which labs you think are useful, which things you wish you had had a lab on and you didn't, okay? So I've got 5 questions for you. It's anonymous. Write whatever the hell you want, okay? And I would appreciate having your feedback because I wrote 2 new labs for next semester, but I gotta have some backing to get them in, okay? And I think we do too damn many of certain labs and not enough of other labs, and some of them suck and some of them are kind of fun, and I just need your feedback on that. So I'm going to put that up for you. It's just 5 questions, okay? I know you got crap to do, but help me, right? Okay, all right, so the last thing on the blood notes is just to talk about inappropriate clotting, okay? So inappropriate clotting is called thrombosis. Thrombosis is the formation of a clot in an unbroken blood vessel. So do you guys remember, you told me last time, which pathway is more likely to start a clot in an unbroken vessel? Who remembers? The intrinsic pathway, right? Because remember that if you let platelets just congregate, even if there wasn't a damage, they'll eventually start to attract one another. Okay, so a clot is called a thrombus. We all form clots. We don't all have heart attacks and strokes because of clots, because most of us have relatively nice wide blood vessels. So a thrombus forms. They form in veins and arteries, but let's talk briefly. Okay, so why is a clot less likely to block blood flow in a vein than it is in an artery? Who knows something about the anatomy of veins versus arteries? Why is it less likely to block blood flow? What do you know about veins? Think about lumen size. No, veins are bigger. Veins have a bigger lumen size. What? They have a larger lumen size. In addition, remember that there are more veins, right? So there's like 3 times as many veins as there are arteries. So even if you blocked one of them, right, it's got an alternate route to get there. And then why is it a bigger deal to block an artery than a vein? Because in an artery, you're on your way to work, right? You got some shit to do. In a vein, you're on your way home, okay? So why do we really care about blockages occurring in arteries? That's why, right? They're narrower to begin with, right? And if you block an artery, you can have some problems. Now, veins are more likely to form, clots are more likely to form in veins because they're lower pressure, right? But they're not as likely to block blood flow in veins. Okay, the most likely place for you guys to form clots, all of us, is in the deep veins of the legs, especially if you're inactive. They don't do much damage, and we have anticoagulants, remember, that are constantly circulating, so usually they'll get broken down, but not always. They cause problems if they get circulated to a narrow artery, okay? And let's talk about how your arteries get narrow, because this can impact things that you're going to do in the future. Okay, so here's a nasty one in the early stages. So what happens in the walls of your arteries is that you get a buildup primarily of fatty plaques related to cholesterol. Most of the time, this is related to what? Smoking is a biggie. Oh my gosh, every single smoker that I've ever dissected, cadavers. They don't all have nasty lungs, surprisingly. Not great lungs, but honestly, the lungs in Utah look kind of like smoker lungs anyway. I hate to tell you that. They really do. They're like, oh, no, those people are just from Salt Lake City. It's freaking frightening. But they all have vessels like this. Like I can cut open an artery and squeeze it, and like just toothpaste is going to squirt out of it. It's gross. So, but not all of us are smokers. So what else? Yeah. High animal product diet is a good way to get this, especially in combination with low activity patterns, which is pretty much America. Pew, pew. Okay, so now What happens is if you throw a clot and then you have an artery that looks like this, it's problematic. If it looks like this, in the later stages, the walls are no longer squishy, they get crunchy. You get calcified walls. You can run your fingers down that artery and you can feel it crackle in the wall, right? This is why this is called hardening of the arteries and not just narrowing of the arteries. And the hardening matters because then the artery is not as elastic. So the elasticity of the arteries helps with blood flow because if you get a squirt and then you snap back, then blood keeps going, right? So you get the hardening. And then in the later stages, you can have almost completely blocked. This is a coronary artery, a post-mortem photo, right? It should be this big, guys. This is the size that the lumen should be. Do you see? So I don't know how to calculate, but it looks like 80-90% blocked. And then if you throw a clot to a nice open vessel, no problem. You'll probably break it down before it causes problems. If you throw a clot to this vessel, can you see how you could have a heart attack or a stroke? Now, how does this occur? This occurs, this is your arteriosclerosis and atherosclerosis projection. You actually start to form the fatty streaks in the walls during the first decade of your life, but it's completely asymptomatic, okay? In the second decade of your life, depending on your diet and activity patterns, they tend to get bigger and start to narrow the lumen, but notice they're still asymptomatic, okay? And then maybe in the third decade of your life, you start to get, for instance, something detectable like high levels of cholesterol in your bloodstream, but most of the time you're asymptomatic. And so when your doctor tells you you've got high cholesterol, but you don't have any symptoms, what do? Not a damn thing is what you do, right? You know you don't, right? And then later on, what happens is the cholesterol starts to build up on the wall and you start to have hypertension. Yeah, hypertension. And then what do? Your doctor says, hey, you've got hypertension and high cholesterol. Then you ask for a pill, right? But you don't do anything else different, generally speaking, right? And then later on, lo and behold, out of nowhere, completely unpredictable, you get a heart attack or a stroke, right? So this is the progression that happens, right? Okay. So, and it is happening to all of us, and I am griping at myself as much as I'm griping at you. Okay, so the clot is not problematic unless it gets stuck someplace. If it gets stuck someplace that's amitotic, you're screwed, right? Like brain, heart, okay? So when it is stationary, it's called a thrombus. When it gets moving, it's called an embolus, and you can throw an embolus to the heart, to the brain, to the lungs. Pulmonary embolism is the least likely to kill you. By the way, an embolus doesn't have to be a clot. It has to be, it's just anything that circulates in the bloodstream and could obstruct blood flow. Like for instance, after diving, you can get an air bubble embolism, right? After breaking a bone, you can get a chunk of fat embolism. But the most likely cause is blood clot embolism. Okay, so now let's talk about causes of inappropriate clotting. What makes it more and less likely that you are going to clot inappropriately, okay? Now, all of us form clots, all of us do, okay? Most of them get broken down and don't kill us. So if you want to increase your likelihood of inappropriate clotting, you can do a few things. First of all, do anything that makes the inner surface of your blood vessels bumpy and rough, because if they catch a platelet, then the platelet can be more likely to attract its friends. And so atherosclerosis, this fatty plaque formation that we've been talking about, does not make a nice smooth inner surface, does it? No, it makes a lumpy inner surface. So atherosclerosis and arteriosclerosis, even before you start narrowing the vessel dramatically, it makes it lumpy. It makes it more likely to catch a platelet. So high blood pressure is a problem as well. High blood pressure eventually will stretch and scar your vessels, and that scarring will make the inner surface rough. Does that make sense? So hypertension or infection resulting from scarring or repeated injections. So if you have repeated injection sites in veins, then you're going to get scar tissue forming in veins. That could be because of repeated medical treatments, or it could be because you've been using heroin. Right? Heroin ain't good for you. This is reason number 252 that heroin ain't good for you, because it increases your lifelong risk, injecting anything into your veins, lifelong risk of heart attack and strokes, because it actually makes your vessel scarred. Okay. Now, what else is bad for you is being really, really immobile. But let's be extreme, like an immobilized patient. They're more likely to form clots, right? Okay, it's one of the many reasons that you're supposed to exercise patients even when they're immobilized. Sitting too long, like on a plane ride to Australia, why do they tell you to get up and wiggle when you're going to Australia? Because they love you? No, because they don't want you to sue them. When you get up, and then 2 days later, as you're walking around Perth, you throw a clot and have a heart attack or a stroke. So you got to wiggle when you're sitting for a really long time, especially since you're more likely to form these in your legs anyway. Now this one I put a question mark on because there's not super strong research on it, but there's suggestive research. But it's something that would be probably healthy to do anyway. So it seems as if only oxidized LDL and VLDL stick to the walls of your blood vessels, right? So if you have high levels of antioxidants in your diet, vitamin C, beta-carotene, selenium, those kinds of things, usually found in brightly colored fruits and vegetables, right? Then it seems as if your vessels are more forgiving of your diet, right? So if you eat a burger, get yourself a nice salad with it, right? Maybe you're going to eat fries too, but then you're going to be fat. But then maybe you won't have cardiovascular disease. I don't know. Okay, so the antioxidants seem to help prevent oxygen from attacking and making your LDL and VLDL sticky. Okay, now smoking is a big one. Smokers have arteriosclerosis, just like almost without exception. Okay, it's a risk factor for thrombosis because it raises your blood pressure, it decreases your vitamin C, and it seems as if, in my anecdotal experience with cutting open a whole bunch of people, that smoking makes every damn thing you eat stick to the walls of your blood vessels, and it also increases your blood pressure by other mechanisms. It also zaps antioxidants from your diet, and they think that's the mechanism by which it sticks everything to the walls of your blood vessels. So that's reason number 3,000 that smoking is bad for you. Okay, you didn't need me to know that, but okay. So the other thing is high levels of estrogen also makes your platelets more likely to congregate, and high levels of estrogen are important during pregnancy, of course. So pregnancy is risky for multiple reasons. First of all, your blood pressure has to be higher during pregnancy because you've got 20 or 30 more pounds, right? Okay. And then second, estrogen increases your likelihood of clotting because it makes your platelets more likely to attract other platelets. So you are at highest risk for stroke and heart attack during pregnancy if you are otherwise healthy. And it's not at all uncommon. Go ahead.
Sorry, to go back to your smoking.
Uh-huh.
How, I don't know how to word it very well, but how much better is e-cigarettes than the regular?
So interestingly, there hasn't been a whole hell of a lot of studies on e-cigarettes. We need longitudinal studies to get something like this because this will be a 20 or 30 year progression that you see with cardiovascular disease. And we don't have that for e-cigarettes. We do have some preliminary information about what they do to lung health. But again, lung health doesn't get dramatically damaged within 1 year. It gets dramatically damaged within a decade or 2 decades. So my personal predisposition would be that I don't want to be the guinea pig that figures out that e-cigarettes jack you up. Because they probably do, right? There's hardly anything that you can do that feels interesting and risky and is not going to kill you in some way, right? The other thing about high levels of estrogen is that hormonal birth control, is estrogen, progesterone, or only progesterone. And in the old days, the birth control pill, I think, came out the year after I was born, which is probably why I'm here, honestly. Because my mom was 17 when she had her first kid. We were not planned children. But in the old days, when they first came out with birth control, it was really high levels of estrogen, and it really dramatically increased your risk of stroke and heart attack. And still, even adding a little bit more estrogen can increase your risk. So for instance, with my heart problem, oral birth control is really not a good choice for me, And if I also was a smoker, then you're basically adding a triple whammy. So I hope that your physicians ask you whether you smoke when you go to get prescription birth control, because you really shouldn't be adding up those factors, right? They never ask you how you eat, but at some point in the future, they probably will. Be like, how many animals do you eat per week, right? And okay, so they tend to make platelets stickier. All right, so now we are going to go to respiratory system, okay? Respiratory system seems complicated. It's actually relatively logical. So I want to give you the big picture understanding of the respiratory system, and then we'll get into the details. Okay, so we'll start with Roman numeral 2. Okay, so here's the deal with the respiratory system. What we're going to have to do is we're going to have to do 4, I guess you could break it down to 4 different things with respiratory system. The first thing that we're going to have to do is we are going to have to get air to move in and out of the body. That is called ventilation, or breathing, right? And ventilation is composed of inspiration and expiration. Okay, here's the basics of how ventilation works. Air flows, like fluids flow, from high pressure to low pressure, but atmospheric pressure is relatively constant, yeah? So all I need to do is change the pressure in my thoracic cavity below atmospheric pressure to get it to move in, and above to get it to move out, right? And I do that primarily by contraction and relaxation of muscles, and I'll teach you guys how that works. That makes sense? Okay, so that's ventilation. And then once I get the air in, I have to do respiration. And there's 2 different categories of respiration. There is external respiration. External respiration is everything before cellular respiration. I do 2 steps of external respiration, so stick with me. External respiration happens first at the pulmonary capillaries, between the alveoli and the pulmonary capillaries. And primarily what we're doing is moving oxygen in and carbon dioxide out, correct? Okay? And you don't have to worry a whole hell of a lot about transport mechanisms because it all works by diffusion. It's pretty damn easy, okay? And then after we've got oxygen in, carbon dioxide out, then of course we take that same blood and we send it back to the heart, yeah? And then we send that blood to the systemic capillaries where we do respiration again, yeah? Only this time what we're doing is we're moving oxygen out of the red blood cells, right? Into the interstitial fluid and then into the cells, right? And carbon dioxide is moving the other way. And the reason we are doing all of that is to serve cellular respiration, which is internal respiration, right? So ventilation, 2 steps of external respiration, then cellular respiration. Got it? So all we have to do is sort of focus on how you get things to move, how to predict which direction they're going to move. But mostly it's relatively logical, and I don't think you're going to have a hell of a lot of a problem with it, with the exception of the fact that there's a little weird terminology associated with it. Okay, so external respiration, you've got to do ventilation, then you've got to do internal respiration. And so let's get started on ventilation. All right, so ventilation and lung mechanics. This is not too bad. So what we have is Boyle's gas law. I don't know if you guys have ever heard of Boyle's gas law. I'm going to bastardize it to simplify it for my purposes. And it basically says that if you take a container full of gas and you squish it, the pressure goes up, yes? And if you can take a container full of gas and you stretch it, the pressure goes down, right? Well, I have a container right here, and it's full of gas, right? And what I want to do is I want to change the size of the container to change the pressure in the container, to pop it just above atmospheric pressure, and then air will move out, or just below atmospheric pressure, and then air will move in, yes? And I do this primarily by contraction and relaxation of these muscles, okay? And the muscles that are going to be involved, the muscles of inspiration are the diaphragm. Diaphragm relaxed is shaped like this. Diaphragm contracted is shaped like that. What does that do to the size of the thoracic cavity? Increases. In addition, with normal inspiration, you also contract the external intercostal muscles, which sort of pulls the ribs up. Okay, so you can feel that. So when you contract the diaphragm and the external intercostal muscles, you increase the size and therefore decrease the pressure in the thoracic cavity, yes? And when you pop the pressure below atmospheric pressure, air will move in. This is a little bit more complicated because we have to figure out why the lungs will follow in just a second. Okay, the lungs are, in a healthy person, stretchy. They call that compliance. The lungs are compliant. So if you pull on them, they should follow you pulling on them. And then when you let them go, they should snap back, okay? We'll talk about determinants of lung compliance in just a second. Okay, so let's briefly talk about how expiration works, and then we'll get to the specifics. Okay, expiration is simply, in most situations, just a relaxation process. So if I relax the diaphragm and relax the external intercostal muscles, I decrease the size and therefore increase the pressure in the thoracic cavity. Usually that alone generates high enough pressure that air moves out, right? So inspiration is always an active muscular process, muscular contraction process, right? Expiration is a relaxation process, okay? However, can you breathe in or out more dramatically, harder? Yeah, of course you can, okay? So if I wanted to do forced expiration, which I don't do all the time, but I can do purposely, or I can do when I'm exercising, forced expiration is like blowing a candle out on a birthday cake, right? And you can do it and you can feel the muscles that are involved. You can go, and of course, you are going to pull together your internal intercostal muscles. It squishes the ribs together. But then what other muscles are involved? Not directly involved, but feel it. Yeah, your abdominal muscles, right? You even sort of pull together some of your back and chest muscles to sort of squish everything together. So that's forced expiration, right? And you can involve a lot of muscles in forced expiration. You can either do it voluntarily or it just naturally occurs when you are working out. Okay, so let's talk about the mechanics of ventilation. Okay, this is going to be relatively familiar to you. Okay, here is how ventilation, what we want is flow. This time we're concerned about airflow instead of fluid flow. But remember, we learned F equals delta P over R, yeah, when we were talking about blood flow. This is the same kind of idea, only one of the P's is always atmospheric P, right? Atmospheric pressure. So what we're going to do to get airflow is to always compare the pressure in my alveoli to the pressure in the atmosphere, and then I have to consider resistance at the same time, right? So this means that if there is no difference between atmospheric and alveolar pressure, then air ain't moving anywhere, right? This means that if atmospheric pressure is higher than alveolar pressure, then air is going to move in. If alveolar pressure is higher than atmospheric pressure, then air is going to move out. Correct? Okay, so F equals delta P over R. Changes in pressure are responsible for changes in ventilation. So the flow of air into and out of the lungs is governed by three principles. The first one is Boyle's law, and Boyle's law is just squish it, higher pressure, stretch it, lower pressure. And the second is the muscles of respiration change the volumes, the size of the thoracic cavity, and therefore the pressure. And then the third is that air moves like blood does from high pressure to low pressure. So let's figure out what would happen. All right, so what we are going to see is, look here. Okay, how do I look at this top portion? So how do I predict where air is going to move? 760 millimeters of mercury is about atmospheric pressure, right? And what I have to do is I'm going to set that at 0 just so I don't have to keep track of 761 versus 759. Does that make sense to you? So we're just going to set that at 0. And we are going to say that if you drop below atmospheric pressure, then you will move air in. Yes? If I go above atmospheric pressure, then I will move air out. What about between breaths? What would you predict about the pressure in your alveoli between breaths? It's equal to atmospheric pressure, right? That makes sense? Okay, so this is normal tidal breathing. That's exactly what's going to go on. So the key is P sub ATM is atmospheric pressure. It's generally a constant 760 millimeters of mercury. If we went to the Himalayas, it would be different, right? But we ain't going there today. But once we got to the Himalayas, it would stable out, not at 760, but at something, right? So all other pressures are expressed relative to atmospheric pressures, okay? So if it's P equals -4, it means it's 4 less than atmospheric pressure. Got it? Okay, so here's your predictor. If alveolar pressure is less than atmospheric pressure, inspiration. If alveolar pressure is greater than atmospheric pressure, expiration. Got it? So you change the size of the container and you change the pressure, and that's what makes things move. One other thing though, and this one is actually interesting, so let's talk about this. The other one is that Why do the lungs move with the thoracic cavity? The reason the lungs move with the thoracic cavity is, and this is important to understand, especially clinically, okay? The lungs move with the thoracic cavity because as I pull on my diaphragm and I pull on my external intercostals, the pleural membranes are stuck to one another because of two things. First, they're moist, right? And you've tried to pull apart two wet slides in a lab, haven't you? You ain't getting the damn thing apart. You better get another slide, okay? And then second, it's negative pressure. It's a vacuum in here. So during development, what happens is the pressure in the fluid between the visceral and the parietal pleura in a healthy person is about -4. So here's what I've done. I've suctioned them to one another and kept them moist. So now when I breathe, right, and I pull out the thoracic cavity, what happens to my lungs? They stretch with it, and the alveoli stretch, right? What would happen though, guys, if you equalized the pressure in the pleural, the intrapleural pressure, which is normally -4, what would happen if you equalized it with atmospheric pressure? Any idea? The lung would collapse. Exactly. It's called a pneumothorax, right? Does that make sense? Okay. Why does it collapse? You didn't even touch it. Because it's stretchy. Yeah, I told you it was stretchy, compliant, right? And the only reason it was staying stuck to the wall was because of the vacuum, right? So this is called a pneumothorax when you collapse a lung because you actually allow the intrapleural pressure to equalize with atmospheric pressure, okay? So what happens when you do this? How do you fix it? Well, first of all, we're really lucky because this one is actually in a separate sac. And if you're having not the worst day of your life, then you're not going to break both of them, right? That one will continue to work. So how do you fix this? Anybody know? Just think about it from a mechanical point of view. Even if you have no clinical experience, how would you fix this? Yeah, you stick a chest tube in there. Do we want to blow or suck with the chest tube? You want to suck. You want to generate some negative pressure, right? You want to actually like suck the air out. The fluid will readhere them, and then you better plug the damn hole, right? Keep the hole plugged. Does that make sense? Okay, so this is called a pneumothorax, and just the problem is that you like equalized air pressure in the intrapleural air pressure with atmospheric air pressure. Now, did you actually damage the lung? Most of the time you didn't, right? So this could, of course, happen with a car accident or something like that, or if you got stabbed, right? Definitely do it. Don't get stabbed. Don't hang around with people who stab people. Okay. The last little thing, and I don't usually test on this, but I will tell you about it just a little bit. The difference between alveolar pressure and intrapleural pressure right here. If it's a bigger difference, then the lungs actually stay stuck to the wall better. So if this P sub IP was -1 instead of -4, then they actually do not stretch as well. If P sub IP is -4, then they actually follow really well. So what we want is we want a decent vacuum in there to make them stay adhered to the wall, okay? That's called transpulmonary pressure. I don't usually test you on that one. Okay, so the expansion is opposed, right? It's opposed by the elasticity of the lungs, right? So you've got this nice little, they should stretch, but they should also snap back. Because remember that the whole expiration process most of the time is passive, right? So when you inspire, you stretch, right? Because of this sticking to the wall. But when you expire, you just relax. And you need that elasticity to have a little snap back, right? Okay, so the movement of air into the lungs, right, is opposed by resistance. And we'll talk about resistance, and then we'll talk about what happens with newborns in just a second. So what is the R? What impacts the R? Well, if you had anything that made your lungs less stretchy, can you see that that would be problematic? Any scarring or fibrosis of the lungs, like cystic fibrosis, like chronic respiratory infections, so that they weren't as stretchy, so they didn't pull out as well or they didn't snap back as well, it's going to increase resistance and therefore decrease flow. Good? Okay. The next thing is the size of the ventilation passageways. What about not the lungs, but the tubes leading to the lungs, the bronchi and the bronchioles? If you constrict those or gunk them up, then you are going to increase resistance, right? Does that make sense? So bronchodilation or bronchoconstriction is controlled by the autonomic nervous system. And in a healthy person, it goes like this. Sympathetic nervous system will cause bronchodilation, right? Parasympathetic nervous system will cause bronchoconstriction, right? But what about in a situation in which you're having an allergic reaction? Well, that's not nervous. That's paracrine, right? And I snort up some pine tree sperm, which is pollen, right? And my body goes, no, I don't want any pine tree sperm up in me. So you do bronchoconstriction, right? Which increases resistance, which causes problems with breathing flow, right? Okay. So what if you have, for instance, a massive allergic reaction, like you are allergic to peanuts and you eat peanuts, and in addition to causing anaphylactic shock, it also shuts down your respiratory, your bronchioles. Well, then you can treat it with epinephrine. Remember epinephrine, right? Epinephrine is basically the same thing as the sympathetic nervous system. So if a person goes into anaphylactic shock and their respiratory ways are shutting down, then epi works for both, right? Because epi will actually cause systemic vasoconstriction but bronchial dilation, right? That's why people carry that stuff around. Good? Okay, and then what about mucus? So what if you have chronic respiratory irritation or problems? Mucus will actually increase resistance because it just like you got stuff gunking up the tube. Good? And this, of course, happens a lot in Utah because our air is really dirty. Okay, the other thing that, and this is going to be an interesting one to talk about. The other thing that increases resistance is that we have to deal with surface tension inside the alveolus. So here's an alveolus, guys, okay? And an alveolus is microscopic. There's like 750 square feet of alveoli in your lungs if you stretch them out. They're microscopic. They're moist on the inner surface because the moisture helps with gas exchange. They're not like too moist, but just a little bit moist. But that causes a problem when you start to stretch them, because if you stretch them and they're moist, then hydrogen bonding will eventually oppose the stretching. Does that make sense to you? In a healthy adult person, when you actually really try to breathe hard, stretching your alveoli makes you release this detergent, which temporarily breaks up the hydrogen bonding. That doesn't work if you've got a preemie, though. And we'll talk about that in just a second, okay? All right, so now, let's talk about some clinical connections. What kinds of things can impact lung compliance? So if your lungs are scarred because of chronic respiratory infection, because of lung cancer, because of whatever, then that is going to decrease the stretchiness of your lungs and therefore increase resistance, right? So let's talk about respiratory distress syndrome of the newborn. You guys have probably, of course, heard that when you have a newborn, especially if they're slightly preterm, even a little bit, the last of your body systems to mature is your respiratory system, because you were really not using it, right? Mm-hmm. Gas exchange all occurs between the baby and the placenta, not between the baby and the lungs. So the lungs are developing, but they're not functioning uniquely, right? So the very last thing to come online is the lungs, and specifically the very last cells to come online in the lungs are what are called type 2 cells. And the type 2 cells, what they do is, I'll find you, here's an alveolus, okay? This alveolus right here is a type 2 cell. If a baby, my son was 2.5 weeks early, not super early, but he was 2.5 weeks early, and his type 2 cells had not come online yet. And what happens is when they try to breathe, their alveoli are opposing the stretching because they've got so much hydrogen bonding. Does that make sense? And so they'll try to breathe, and since breathing in is a muscular contraction, it's really, really hard to breathe in, but then their lungs just kind of collapse back down because the elasticity of the lungs will cause them to collapse, and their little chests just look terrible. Okay, so that's the type 2 cells. So if you have a baby that's born prematurely, they can't make this detergent called surfactant. And surfactant is what you make when you breathe heavily, and it allows you to temporarily break up the hydrogen bonding on the inner surface of the alveoli. So this affects preemies. It can also affect full-term babies. Their type 2 cells aren't functioning adequately. The surface tension is so great that their alveoli will not expand. Now, it was bad with my son because he was 2.5 weeks early. And in addition to being 2.5 weeks early, I also had to deliver him by cesarean section because I've got a heart problem and I can't go through labor. So you get a double whammy there. I know a lot of women do planned cesarean sections, but let's just be honest, it has risks associated with it. The risks for me and Evan were greater because we would have both died if I went through labor. So here's what happens in a normal vaginal delivery. In a normal vaginal delivery, your baby goes from being an aquatic organism, right, surrounded by amniotic fluid, and as they go through the vaginal canal, it squishes the fluid out of their lungs. Does that make sense? So that by the time that they're born, right, if they're full term and their type 2 cells are working well, they should be able to take their first breath and everything is well, right? So I had a double whammy with Evan when he was born. A, he was born 2.5 weeks early, not by choice. And then B, he was born by cesarean section, right? So when he came out, what happened is he was straining really hard to breathe because he had extra fluid inside of his lungs. And in addition, he had no type 2 cell function, right? So what happened is he actually strained to breathe for a few minutes and then popped a pneumothorax or a mediastinothorax, and one of his lungs collapsed. And it just happened from this side instead of from that side. Go ahead.
Is that why they wait to see if when the baby starts crying?
Yes, they're looking for proper lung function, and they also wait for him to peak up. So he popped a mediastinothorax and one of his lungs collapsed. But luckily, now we know, first of all, they knew I was a high-risk pregnancy, so they were taking care anyway. But now we actually know how to make surfactant in the lab. So what they do with babies like that is, of course, they took him away from me. They put him in an incubator. They gave him 100% oxygen. They gave him a chest tube and sucked out his little lung and let it heal, right? And then they gave him surfactant into his lungs, right? Along with steroids to help his lungs mature, right? And so he was in the hospital for like 12 days, but I had to stay with him anyway because my doctor lied and said, I'm really concerned about her heart. Nothing, I was fine. But he didn't want me to have to leave. So anyway, that's what happens. So pregnancy is really risky, and cesarean sections, I know that a planned cesarean section is actually easier to recover from, which is why some women are choosing to do them. But they are dangerous, and they are more dangerous for the baby than a vaginal delivery, FYI. Although I'm not one of those bastard moms who's going to tell you that if you have a baby the wrong way, you're not a real mom. Have you heard those arguments? Don't even get onto mommy blogs. Those people are horrible. There's a lady at my son's school. He goes to like this hippie school, and there's like, birth the way that God intended. I'm like, what do you mean, like 30% mortality rate? Is that what you mean by the way that God intended? Bubonic plague by the time you're 7? Is that what? Shut up. I hate you. It's like, I just want to flip her off every time I see her.
That's the OC, isn't it?
Yeah, it is the OC. Yeah. Yeah. I mean, I love me some hippies until they start trying to talk about science. And then I'm like, sit down. The grown-ups are talking. Okay. All right. So clinical connections. Just quickly with these. So problems of ventilation can be problems of pressure, but it's usually resistance that causes problems with flow. So COPD is chronic obstructive pulmonary disease. It's anything that increases airway resistance, like bronchitis would, right, because of inflammation and mucus. Emphysema, do you guys know about emphysema? Okay, emphysema, first thing, which is usually because of chronic respiratory irritation. Like smoking is a good way to get emphysema, but so is working in a coal mine. So is probably living in Utah in the winter, honestly. So what happens is the alveolar walls will lose their elasticity in the early stages so that they don't stretch as well, right? So you're impacting compliance. And then later on, instead of having a bunch of little bitty grapes, microscopic, you get grapefruit, right? So I'll show you lungs, healthy lungs, and then lungs with emphysema. Okay, so here's what a healthy lung looks like. It is so incredibly dense. It looks like one of those really expensive Williams-Sonoma sponges, right? It's really, really dense, okay? So, and it's got about 750 square feet of surface area in both of your lungs combined. But when you get emphysema, here's what happens. Here's a lung with emphysema. So you're breaking down your alveolar walls and decreasing your surface area for gas exchange. Does that make sense? So it, of course, increases resistance, right? But it also decreases flow because you're not getting as much air actually into, or as much oxygen into the body. Okay, so that's emphysema. Have you guys seen the cadaver on, I think it's on Redwood campus. It's on Redwood, right? With emphysema? I don't know if we have two or one. I can't remember. I keep moving the cadavers around, so I can't remember where it is. No, he doesn't have emphysema. So we had this guy who, they said he died of COPD. So when we get the cadavers, I'm the cadaver person, and I'm always like super excited because it's like a Cracker Jack box in there. I'm like, woo, what are we gonna find? So he died of COPD. I donated my body, so I can be weird. I already have done the paperwork. You guys can cut me open later. He died of COPD, and then when we got into his lungs, I touched his lungs, and I like the texture of lungs as it pretty expected. His were super crunchy, and my finger kept going. So I just cut open a little window, and he has bigger holes than this. It's the weirdest, coolest thing. I don't know. You guys don't think that stuff's cool, but I do. Okay. What? Yeah. I'm really surprised that he lived as long as he did. He had his huge bubbles. Some of his bubbles were that big in his alveoli. It was crazy. Okay. So what is asthma? Asthma is when you have smooth muscle contraction in your bronchioles. Can be due to allergy, can be brought on by emotion, can be due to air irritants. But it's often accompanied by mucus accumulation. So what's the problem with asthma? Is it pressure or resistance? It's resistance. So asthma can also cause COPD. So what do you do for asthma? You give anti-inflammatory antihistamines. You also give bronchodilator drugs. And if it gets super duper bad, they can give steroids for it. Lung cancer accounts for 1/3 of all cancer deaths, but only 90% of the people who get lung cancer are smokers. Would you not be pissed off if you got lung cancer and you never smoked? Be like, damn, I should have done some stuff in my life. Pneumonia is an inflammatory condition in which basically what happens is you end up building up excess fluid, and the fluid builds up inside your alveoli and causes problems with gas exchange, and it feels like you're drowning. Has anybody ever had pneumonia but me? Oh, it's so terrifying. You're just on the ground and drowning. You can't get any air in. I woke my husband up in the middle of the night. I'm like, I'm drowning. He's like, what? What are you talking about? No, seriously, I was drowning. Okay. So now what we are going to do is we're going to talk about respiration. So we talked about ventilation. Now we're going to talk about respiration. Respiration is not outrageously difficult because you already know, having been awake all semester long and last semester, you already know where oxygen should be high and low and where carbon dioxide should be high and low. So what we are going to do is we're going to talk about sort of what happens at the pulmonary capillary beds and then what happens at the systemic capillary beds. That make sense? Okay. So this is external respiration, which serves cellular respiration. But before we get into it, I just have to introduce you to a term that I don't like any more than you do, but we have to talk about it anyway. Okay. Instead of talking about oxygen moving down oxygen's concentration gradients, they talk about partial pressure gradients. So here's the deal. With gases, the 760 millimeters of mercury is the pressure of all of the gases, right, collectively. And it's nitrogen gas, which we don't care about. Of course, we care about oxygen and carbon dioxide. We really don't care about water vapor very much. There's a bunch of other ones out there. So collectively, that's the total pressure, right? 760 millimeters of mercury. So what we say is oxygen moves down its partial pressure gradient. The pressure that it has in the atmosphere compared to the pressure that it has in here. Now, why don't we just say concentration gradient? Because you can change the way that gases move by heating them up or squishing them. So it's not just concentration. But I'm not going to heat you up or squish you. So for all practical purposes, you can say that, although a physicist would definitely disagree with me, and it would change if you were on Mars, but we're staying here. PO2, the partial pressure of oxygen, is roughly equal to the concentration of oxygen. Yes? Okay. PCO2, the partial pressure of carbon dioxide, is roughly equal to the concentration of carbon dioxide. Here's the other thing. Oxygen doesn't give a crap what any of the other gases do. Oxygen moves down its own gradient. Carbon dioxide moves down its own gradient. Does that make sense? So nobody uses oxygen concentration. They all use partial pressure. Okay, but until you like go to the Himalayas or go to Mars or heat yourself up or squish yourself, it's not going to make any difference whether you think about it this way or not. Okay, so we're going to call it PO2 and PCO2. Okay. So gases are going to move down their own partial pressure gradients from high to low. Each gas in the mixture behaves as if the other gases do not exist. So it's very similar to saying that gases move from high concentration to low concentration. Okay, so here's what we're going to do. We're going to do external respiration. External respiration has two steps. What happens at the pulmonary capillary beds, what happens at the systemic capillary beds. All we're trying to do is to serve cellular respiration. Okay, so stuff that you guys are going to know is that the site, of course, of the first of external respiration is at the pulmonary capillaries, and it's between a capillary and an alveolus. Yes, capillary and alveolus. The capillary and the alveolus are both microscopically thin, right? Lots and lots of thinness and 750 square feet of surface area. So this area where you do gas exchange at the pulmonary capillary beds is called the respiratory membrane. It's about 1/6000th of an inch thick, or 0.2, what does it say, meters? It's not meters. It's 0.2 micrometers, not meters. That matters. 0.2 micrometers thick. So it really is just one layer of simple squamous epithelium for the alveolus and one layer of simple squamous epithelium for the capillary, with just a stretchy basement membrane in between, no connective tissue between them. Okay, so that's the respiratory membrane. It is about 750 square feet, or about 25 foot by 30 feet. I've lived in apartments smaller than that. Some of you guys probably have too, right? So it's incredibly effective for gas exchange. In addition, the lungs get a disproportionate amount of blood. At any given moment, the lungs have about 1 liter of blood going through them. Okay, so the respiration process, you guys know the respiration process. Here it is, okay? You're going to deliver blood to the lungs from the pulmonary arteries, yes? Think about it, don't look at it. The blood in the pulmonary arteries is high what, low what? High CO2, low oxygen, yes? And then, of course, it's going to go by those alveoli. And, of course, the air that you are breathing in is high what, low what? High oxygen, low CO2. And all that happens is they just diffuse down their partial pressure gradients, right? And so exactly what you would expect to occur occurs. Go ahead.
So does the pulmonary system have the highest acid concentration at the bottom?
What did you say?
Does the pulmonary system have the highest
I can't hear the first word. Does the what?
pulmonary system?
No, it doesn't.
Have the lowest pH in the body?
It has the lowest pH in the body, yes. And we're going to get to that in a minute, too. We'll talk about the acid relationship. Everybody good with that? Okay, so basically what we've got is we've got the blood that's coming in and the oxygen that's coming in, or the air that's coming in, are going to be different. Things are going to move down their concentration gradients, right? So what we have to do now is put this together with the idea of hemoglobin. So now instead of just saying oxygen moves into the blood, we're going to say, okay, oxygen moves into the blood, inside the red blood cells, and goes and sits on the heme portion of hemoglobin. Yes? Okay. What does that do to the color of the blood? Of course, it makes it redder, right? Okay, so now I want you guys to be thinking for the rest of this lecture about hemoglobin as your oxygen ferry, right? And what we're going to start doing is getting to the point that we can predict when hemoglobin would pick up oxygen, yes, load it, saturate, and when hemoglobin would drop off oxygen. So before we go any further, let's predict. Pulmonary capillaries, hemoglobin should do what to oxygen? Load or unload? Load, yes, okay. And then systemic capillaries, hemoglobin should do what? Unload, got it? Okay, so keep that in mind. All right, so gas exchange now, so we just did what's going to load and unload. Let's talk about carbon dioxide a little bit before we go into the systemic capillaries. So with carbon dioxide, you carry it in a little bit different way, okay? With carbon dioxide, please remember that hemoglobin can carry a little bit of carbon dioxide at the same time as it carries oxygen. They don't compete with one another because it goes on the globin portion, not the heme portion. Okay, so what's going to happen as you go by the pulmonary capillary beds to carbon dioxide? Is it going to load or unload carbon dioxide? Unload, right? It's going to do the opposite stuff, right? Okay. All right, so now let's talk about gas exchange between systemic capillaries and tissue cells. So now I want to talk about what's going to go on down here. So we just did this part, and we said, okay, we know which direction oxygen is going to move at pulmonary capillary beds, and we know which direction carbon dioxide is going to move at pulmonary capillary beds, right? We're going to go back to the heart, and then we're going to pump to systemic capillary beds. And we also know this, yes? At systemic capillary beds, what do you predict about loading versus unloading of oxygen off of your hemoglobin ferry? What should happen? At systemic capillary beds, what do you predict? Unload. Yes, you need to unload, because ultimately what you were doing is you were trying to serve cellular respiration, yes? So you need to get the oxygen off of hemoglobin into the cells so that they can do cellular respiration, right? So all of this business that we've been talking about is all serving the master of cellular respiration. That's what it's doing, okay? And then with carbon dioxide, what's going to happen is you will move it into the bloodstream. Okay, so here we go. What we are going to do now is we're going to watch an animation. We're going to try to serve cellular respiration. Now, with this, he goes into the numbers quite a bit, but I don't care if you memorize the numbers. What I care is that you understand and can predict where things are low versus high, right? So you can compare 104 to 90 to 76, right? Then you know the direction, right? Okay. And please note what cellular respiration is doing.
Carries oxygen with a PO2 of 160. The presence of moisture in the lung results in reduction of the PO2 to 104. Fresh air entering the lung carries carbon dioxide with a pCO2 of 0.3. The carbon dioxide delivered to the lung from the blood raises the pCO2 to 40. At the arterial ends of the pulmonary capillaries, oxygen diffuses from the air in the alveoli into the blood, and carbon dioxide diffuses from the blood into the alveoli because of differences in partial pressures. As a result of diffusion at the venous ends of the pulmonary capillaries, the PO2 in the blood is equal to the PO2 in the alveoli, and the pCO2 in the blood is equal to the pCO2 in the alveoli. With no differences in partial pressure, there is no more net movement of oxygen or carbon dioxide.
Okay, so all he's saying is once you even out the concentration, partial pressure gradient, then basically you stop it moving, right? And that's what happens at the venous end of the pulmonary capillary beds, right? And of course, now we're going to go back to the heart, and then we're going to deliver to systemic circulation.
Oxygen diffuses out of the arterial ends of tissue capillaries into the tissue fluid, then into the cells, and carbon dioxide diffuses out of the cells into the tissue fluid, then into the blood because of differences in partial pressures.
So notice oxygen, high, medium, low. And notice carbon dioxide, high, slightly lower, lower, right? One of these three places is never going to be satisfied. Okay, let's see which one.
At the venous ends of tissue capillaries, the PO2 in the blood is equal to the PO2 in the tissue fluid, and the pCO2 in the blood is equal to the pCO2 in the tissue fluid, resulting in no more net movement of oxygen or carbon dioxide. The blood now carries the oxygen and carbon dioxide to the lungs.
So which of these guys is never actually satisfied? Yeah, the cells are never going to be satisfied. So cellular respiration is actually the driving force of all of this, because in the absence of cellular respiration, you wouldn't have any concentration gradient for oxygen or carbon dioxide, right? By the activity of the cells, you're constantly generating low oxygen and high carbon dioxide, which is the driving force of all of this, okay?
And carbon dioxide to the lungs. In the body, all of these exchanges occur simultaneously.
That's why you're tired all the time. Like, damn it, I'm doing so much, right? Okay, all right, so the next thing that we are going to talk about is how these things move around, okay? And it's really not too bad. So I want to talk about how you transport oxygen, and then we'll talk about how you transport carbon dioxide, okay? So how it moves from point A to point B. So how you transport oxygen is pretty much how you'd expect to transport oxygen. The vast majority of your oxygen goes inside the red blood cell and rides on the heme portion of hemoglobin. So about 98.5% of your oxygen is traveling in your blood on hemoglobin at any given time. Now, a little bit of it is on its way in or out. So you got like 1.5% at any given time that might be outside of the hemoglobin. Does that make sense? Okay. So again, I want you guys to think about hemoglobin as an oxygen ferry, right? Carrying it around. And what we're going to do is to figure out when you would form oxyhemoglobin and when you would form deoxyhemoglobin. Now, in order for hemoglobin to be a good ferry, it has to be able to pick up and let go very readily. Does that make sense? The reason carbon monoxide is a bugger is because carbon monoxide will sit onto hemoglobin, take up oxygen's seat, and never get out, okay? So we'll talk about carbon monoxide when we get finished talking about hemoglobin in just a second. So here's what I want you guys to do. I want you to think about, before we go any further, which set of capillaries, pulmonary or systemic, should favor loading of oxygen onto hemoglobin. Which one? Pulmonary. And then systemic should favor unloading. So here's what we're going to do. We're going to look through factors that favor loading and factors that favor unloading. And it's going to seem like memorization until you remember that you already know the answer. Because you already know that everything that is true at the pulmonary capillary bed should favor loading, yes? And everything that is true at the systemic capillary bed should favor unloading. Does that make sense? So it'll seem complicated and then it'll clarify. All right, you guys ready? So factors that determine how much oxygen combines with hemoglobin. It determines hemoglobin's affinity for oxygen, yes? Okay, or how much hemoglobin will saturate with oxygen. So affinity, saturation, loading, all kind of the same idea. Okay, okay. So the first one is the PO2. PO2, which is akin to the concentration of oxygen, right? So this is a simple one. If there is more oxygen, then it is more or less likely to load. It's more likely to load. And also, which capillary bed has higher PO2? Pulmonary or systemic? You should know this. Which capillary bed? No. Which capillary bed has higher PO2? Pulmonary, right? Because you just brought in a whole bunch of oxygen. So here's the deal. And this one seems completely obvious because it is. The higher the PO2, the more you will load oxygen onto hemoglobin. Yes? The lower the PO2, the more you will unload oxygen off of hemoglobin, right? So this is called saturation. In lungs, hemoglobin is 90% saturated, even when your PO2 is only 60 because the air is 104. So the air is always way higher than the blood, right? So it goes on to it really quickly. Okay, so where PO2 is low, comparatively speaking, PO2 is lower in systemic capillary beds, then you are more likely to unload oxygen off of hemoglobin, right? To desaturate, right? Which is exactly what you wanted. Okay, so now let's do the next one. This directly relates to Abel's question earlier. All right, so I want you to, before we go any further, I want you to try to predict which capillary bed would be lower in pH. Pulmonary or systemic? Systemic. Why? Carbon dioxide. You've learned that carbon dioxide relationship before, like 5 times this whole freaking semester, right? So higher carbon dioxide, of course, you know the relationship between carbon dioxide dissociates to carbonic acid and goes to H+ and bicarbonate ion, right? So does everybody agree that with that in mind, your systemic capillaries should be lower in pH? Yes? So now you predict to me whether high pH should cause you to load or unload oxygen onto hemoglobin. Load. High pH should cause you to load Low pH should cause you to unload. Yes? Because if you compare the two capillary beds, which one would have a higher pH? The pulmonary capillary bed, right? And the systemic capillary bed would have a lower pH. Does that make sense? And it's because of the carbon dioxide concentration. So here is that picture. Let me show you that one. Yeah. Okay. Here is the affinity of oxygen for hemoglobin at low pH, lower affinity, right? You're going to drop it off more. At higher pH, higher affinity, you're going to pick it up more. Does that make sense to you guys? Okay. So, PCO2. Okay. Before you try to predict, tell me which capillary bed will have a higher PCO2, systemic or pulmonary? Systemic. So now predict what PCO2 will do to loading or unloading. Higher PCO2 will cause you to load or unload? Unload. You would be right. Yes. So increase in PCO2 drops off oxygen from hemoglobin or unloads oxygen from hemoglobin. Yes? Okay. And a lower PCO2 does the opposite. Okay, temperature. Let's think about this one. In really, really metabolically active tissues, right, the temperature tends to increase. You guys with me? Okay. So now let's compare a really metabolically active organ like maybe the liver or maybe skeletal muscle when I'm working out. Compare the temperature of that one to the temperature of my lungs. Which one's probably going to be higher temperature? The metabolically active tissue, right? Okay, so what do you think temperature does? Should temperature make you load oxygen onto hemoglobin or unload oxygen off of hemoglobin? Unload, yes. Yes? Higher temperatures tends to make you unload off of hemoglobin. Does that make sense? Okay, so the lungs are usually slightly cooler than respiring tissues, okay? Unless you're breathing in air that's like 125 degrees, they're usually slightly cooler. So the relationship is an increase in temperature causes oxygen to split off of hemoglobin or decreases the affinity. An increase in temperature unloads oxygen from hemoglobin. Unloads oxygen. This happens in active tissues, happens due to exercise, etc. Okay, almost done. Last one. This one's kind of a weird one, but I think I can make it make sense to you. DPG or BPG, 2,3-bisphosphoglycerate or 2,3-diphosphoglycerate, is produced by red blood cells during their own metabolic processes. Red blood cells only do glycolysis, though. They don't do oxphos because they don't have any what? No. They don't have any mitochondria, right? They've lost most of their organelles. Okay, so here's what red blood cells do. Red blood cells are your little oxygen ferry, but they don't use oxygen. Oxygen's for their buddies, right? They're just carrying it around for you. They don't even need it, okay? So what happens is if the metabolic activity of tissues increases, then often the metabolic activity of a red blood cell increases. And the red blood cell produces BPG as a byproduct of its glycolysis. And when the red blood cell produces BPG, it says, hey, I'm really busy. I bet you guys are too. And the BPG causes you to push oxygen out of hemoglobin. Does that make sense? Because the red blood cell says, I'm super busy. I'm going to hook up my homies, right? And I think if I'm really busy, I'm going to push oxygen out. So as BPG increases, and it's going to increase more as you get more metabolically active, then what's going to happen is it will decrease the affinity or increase the amount of oxygen that you drop off, okay? So the relationship, increase in DPG causes you to drop oxygen off of hemoglobin for use, right? That makes sense. Okay, so let's look at the summary. Here's the summary where it'll get easy again. Okay, so here's what you do. You think about what should be true in systemic capillaries and what should be true in pulmonary capillaries, right? Okay, everything that happens in pulmonary capillaries should favor what? Loading or unloading? Loading. Everything that happens in systemic capillaries should favor unloading. So let's match that together. So everything that happens in systemic capillaries should favor unloading. So does it make sense to you that here's the things that favor unloading, the things that are true in a systemic capillary? It has a decrease in PO2 compared to pulmonary capillaries, less PO2, right? A decrease in pH compared to pulmonary capillaries, yes? An increase in PCO2 compared to pulmonary capillaries, got it? An increase in temperature, especially if it's more active compared to pulmonary capillaries, and an increase in BPG if it gets more active, because the red blood cells get more active. right? So all of those things are things that are true at systemic capillaries and therefore favor unloading of oxygen. Good? Okay, what's true at pulmonary capillaries compared to systemic? Pulmonary capillaries should have more PO2, higher pH, yes? Okay, decreased PCO2 and decreased temperature, and also likely a decreased BPG, and that would all favor loading, right? So the way that I think about it, I hope that you can hear, is just figure out what is, so you know what should happen at a systemic and a pulmonary capillary bed, and then match all of the things that are true to that systemic or pulmonary capillary bed, and then figure out whether they load or unload, right? Because you already know that, okay? Good? Okay, so there's a good summary in figure 1713 if you want to look at it. So let's talk about carbon monoxide again. Carbon monoxide is a bugger. Here's what carbon monoxide does. Carbon monoxide gets onto the oxygen ferry and it has a greater affinity for hemoglobin than oxygen, okay? And it doesn't get out of the seat. It just gets on and it never leaves. Not never, but it's really hard to get it out of the seat. So for instance, if I am breathing in carbon monoxide, especially in a closed space, then what happens is when I breathe in carbon monoxide, it takes an oxygen seat on the hemoglobin. I circulate it around. It doesn't get off, right? It almost never leaves. It's got a greater affinity. And then the next time I breathe more of it in, it takes up more of oxygen seats. The interesting thing is it makes your blood bright red because carbon monoxide bound to the heme group of hemoglobin makes your blood red just like oxygen does. So your blood would be bright red and you'd be kind of ruddy, but you would literally be starving your cells of oxygen, right? So it happens every damn winter. Carbon monoxide poisoning, especially here in Utah, you have to be careful because most of our homes are not heated by electricity directly, they're heated by natural gas. Carbon monoxide is a byproduct of burning fossil fuels or burning organic material, I should say, because it also happens with wood. And the reason that it's worth talking about is that I know that some of you guys already know it and some of you don't because you actually haven't really managed your own home yet, right? Some of you have. So the deal is that it is colorless, it is odorless, and it's not what you would smell if you left your gas stove on, because that's what it smells like prior to burning, and they actually put that smell in there so you could smell it, right? But after it burns, if you don't have proper ventilation of, for instance, your heater or something that is actually going inside your home, the carbon monoxide will kill you just by making you super exhausted and feel a little bit flu-like, and then you'll go to sleep, and then you will not wake up, right? And it happens every single winter. Go ahead.
Don't they have sensors?
Oh yeah, you have a carbon monoxide detectors. Every single Utah home should have one for sure. And you also probably should check them to make sure that they're still functional. And kids die of carbon monoxide poisoning more quickly than adults. I have a lot of personal experience with this because I'm from Texas, and for some reason in Texas, we have a special brand of redneck in Texas. And every single winter, everybody's super, super shocked that it gets cold. Every time. It's just like, it was cold last winter, and then it gets cold. And they're like, oh, we didn't check our heater. And I know you think it's hot in Texas, but it's just unpleasant generally. It's super freaking hot, and then it's super freaking cold, and you don't even get any snow. So it's like sleet, rain, freezing, everything. And it gets really cold, and then people are like, oh shit, it's cold, what should I do? And then they turn on their heater, and the heater doesn't work. But everybody's got barbecue grills. So they pull the damn barbecue grill inside the house, and everybody dies. Right? Don't pull your barbecue grill inside the house, right? Go to grandma's, go do something else. Yes, it happens all the time. Okay, so what we're going to do next time is we will briefly finish up carbon dioxide carriage, and then we will start urinary system. We have time to finish both. We'll be fine, okay? I will probably on Thursday post a quiz for you over the weekend, a long one to make you practice, okay? And if you don't do it, don't email me and tell me I should have done it, because hell yeah, you should have done it, all right?